Now coming to the main treatment, this is a very important slide which gives you the basis of everything which we are learning today. So we cannot give estrogen alone with a woman who has a uterus. That is the key line you have to understand. So if we give unopposed estrogen, because that means estrogen without progesterone, with a woman who has a uterus, that means we are putting her at a risk of developing endometrial hyperplasia and cancer, because estrogen without progesterone will just keep on increasing the endometrial thickening, the lining. And when there is no unopposed and you just give estrogen the freedom it wants to grow, it will grow without direction, and the woman will end up in hyperplasia and cancer. That's why we give a combination of estrogen and progesterone treatment for women with a uterus. So the treatment can be given in a sequential manner or a combined continuous fashion manner with a low dose of progesterone. We only give unopposed estrogen to women who have been operated and the hysterectomy has been done. That implies that there is no uterus, no endometrium, so there is no chance for that. That is the only scenario which we can give. So who needs HRT? Women who have all the symptoms which we have discussed above, who people who have gonadal dysgenesis like Turner's and all, high risk cases of developing osteoporosis like a family history of having osteoporosis or cardiovascular disease or colonic cancer, premature menopause, either because of the surgery or chemotherapy or radiation, who have these vasomotor symptoms, who have dyspareunia, decreased libido, or urethral symptoms. Apart from all this, if a woman is having a bad quality of life, if she's not able to sleep properly, if she's not able to go out and enjoy the things which she used to do previously, and it is affecting her quality of life, that means she is suffering from that and she needs to be treated for that. So before starting hormone replacement therapy, a woman has to be evaluated. She has to be a detailed history and a physical examination, which includes the breast examination, and a pelvic examination has to be done. Her blood pressure should also be monitored, and if it is high, treatment with medication to control her blood pressure has to be done. Baseline thyroid level, HbA1c, and lipid profile has to be done, because I'll tell you in the next slides, I'll tell you the side effects and all which happen because of hormone replacement therapy. A pap smear and mammography have to be done just to rule out any cancers which can be there, and a baseline ultrasound has to be done. So after doing all these and concluding everything is wrong, then a woman can be considered fit for giving hormone replacement therapy. So when do we start hormone replacement therapy? We start hormone replacement therapy if she has a valid indication. That means if she's suffering from any of the symptoms which I've mentioned before, or if she's having a risk of developing osteoporosis in the future, then it's a valid indication. No contraindications. So I will be telling you the contraindications too in the next slide. And preferably before the age of 60. I have mentioned the word preferably because it is not an absolute thing that, a woman above 60 should not be started. Technically, the risks are more than the benefits after the age of 60. But if the woman is very healthy and she's following up with, a proper, she's following up properly with you, then you can consider putting her on her HRT after 60 years. So the point is, within 10 years of her final menstrual period, it is the best time. So there is a window period in which you can start hormone replacement therapy. That is when, like during the perimenopausal period, when she just entered her menopause, that is during the early menopause period. That is the time in which it is the window opportunity, and you will get the maximum benefit out of hormone replacement therapy before. So once her period start and you wait for 10 years, and then she thinks that, like you think that, oh, she's at a risk of osteoporosis and all. That time, if you do give estrogen, even with progesterone, you might end up, causing more damage to her and putting her at more risk rather than the benefit. So it is important not to miss the window period. So let's go into detail about the drugs used. So the principal hormone in HRT is estrogen. You can either be giving conjugated estradiol or 17 beta estradiol. This is also called as estrogen valerate, also known as Proganova, which can also be given. And the progestins used are medroxyprogesterone acetate, microionized progesterone, and dydrogesterone. Compare it to the initial ones, conjugated estradiol and medroxyprogesterone acetate. The newer ones have a better safety profile and lower risks. So dydrogesterone and the 17 beta estradiol, they are comparatively better to be given. But these are the old regimens and all, which also have good benefit and all, but a constant follow-up and watch is also required. So if you're giving a oral only estrogen regimen, you have to give estrogen conjugated ethinyl estradiol 0.625 mg or 0.3 mg. This is to a woman who already has a hysterectomy. Whereas a cyclical regimen is given where the estrogen is given continuously for 25 days and the progesterone is given in the last 10 days. So we're actually mimicking the hormone flow of the menstrual cycle. So that is what we're doing. Whereas a continuous estrogen progesterone therapy, you give it continuously instead of giving it in the last days. The other modes of administration which have come are the transdermal implantation. Transdermal administrations are, you can either give an implant or you can give an estrogen gel or you can give a patch. These are actually, they bypass all the side effects of increasing the lipid profile and all, and they're actually a better choice for women who have restrictions or contraindications for giving HRT through the oral way. So 17 beta estradiol is the main hormone which is used over here, and it is really, given for women, and it lasts for around 6 months. It is applied below the waistline and changed twice a week. So tibolone is also another one. It is in the 17-nor testosterone derivative. It is also a selective tissue estrogen activity regulator, also known as TR. It has weak estrogenic and progesterogenic and androgenic properties. It has to be used in caution with breast cancer because it increases the recurrence. The dosage of tibolone is 1.25 to 2.5 mg per day. These are the newer drugs which have come. Like testosterone has already been there since a long time, but it always is in a controversial state whether it has to be given or not. So transdermal testosterone has, given few women better benefits compared to the estrogen. It is given to women who have only dyspareunia, decreased sexual libido, and decreased lubrication. So it is beneficial when it is given intravaginally, when it is used around 3 to 4 times a week. So there are a few gels which are available in the market, but I would prefer like the local estrogens is much better compared to the testosterone. There's a newer drug called as it's a 3rd generation SERM, which is a osmifene. Dosage is 60 mg, and it is used for treatment of moderate to severe dyspareunia. So the women who are not able to tolerate the local or systemic estrogens, who are not indicated for them, this is a better choice of drug. Intravaginal DHEA is also then, but the safety profile is not much studied. So this is something which maybe in the future could be a better option. So transdermal therapy and low dose regimens, what are their advantages? When you give oral dosages, the dosage is higher compared to the transdermal. Transdermal is something which will act over the 6 months. It has less effects on your clotting factors, the triglycerides, the C-reactive protein, and blood pressure. But there is no large-scale randomized trials, but this is a wonderful option for women who cannot tolerate taking the oral estrogens, or who have an active liver disease or a gallbladder disease, or who have dyslipidemia, high blood pressures. This is a wonderful drug for them. So these are the people who should be considered for transdermal, who are obese, diabetes, hypertriglyceridemia, increased risk of thrombosis, low libido, migraines, and gallbladder. Transdermal is a wonderful option for them instead of taking the oral medication. So the contraindications of hormone replacement therapy. women who have breast cancer or uterine cancer or family history of cancer. Breast cancer, I would say, is a relative contraindication. If the woman had a history of breast cancer and she had been treated for it, later, she has already gone a risk reducing surgery, she's already been treated everything, and now she's in her relapse period. Then if she's suffering from all the postmenopausal symptoms, with cautious monitoring and all, we can give her HRT. The same goes with all the other risk factors also. If she has a previous history of thromboembolic disorder, liver or gallbladder disease, lipid profile dysfunction, or a coronary artery disease. I'll be discussing regarding the coronary artery disease in detail later. So these are the contraindications, but all the contraindications, I would say, it has to be tailored to the patient. Like every patient is different. If she does have even any of the problems are there, with cautious monitoring and all, she can be given a trial, or she can, instead of giving her oral medication, transdermal or the non-hormonal medications can also be considered for her. So how do we start and stop HRT? So we have to explain to the woman that after starting, HRT, she will have little vaginal bleeding, and it should be reported to the woman. This is according to the NICE guidelines. So we have to explain that the HRT may limit recurrence of symptoms in the short term, or and gradually reducing or immediately stopping them makes no difference to their symptoms. It's going to be the same. And she has to also be explained that once she stops her HRT, that symptoms are going to come back. This is not a permanent cure. It's just for her to feel better for a few more days and to prevent the long-term risks. So when to stop? When the symptoms subside, or typically around 2 to 5 years. There is no time limit that you have to stop after 5 years. If the patient is doing well and all her parameters are normal and she's following up normally, it can be given for her, even for longer. Even if she crosses 60 years also, if she is following up, I do not see any need to stop the medication just because she has crossed the 5-year limit. So if she has any serious adverse effects or intolerable side effects, or she's already in primary ovarian insufficiency, she has reached her natural age of menopause. So she has reached around 55 years. So when if she has stopped her periods around 38, and you have started and she's reached 55 now, she has already taken around 15 years of HRT. That means it would be a natural age of menopause for her. So it's a good time to stop. So how to stop? Usually we taper the medication so that the woman feels better, but technically even if you stop it abruptly or even if taper, the symptoms are going to come back no matter what. You have to counsel her regarding that, and even after stopping the medications, she has to come for assessment and annual follow-ups. So once we start her HRT, the woman should be scheduled for a visit after 1 month to check the side effects of the either the tablets or the intradermal patches, whatever form of medication she's taking. We have to follow her up after 1 month, and again after 3 months to assess the efficacy and the tolerability of the medication, and after that annually once to see if she's doing fine, or unless if she has any clinical indications to come earlier, like if she's having any side effects or adverse effects. So the woman should be counseled regarding all the side effects and the adverse effects which can happen. And if she does have any of those symptoms, she should follow up immediately. Otherwise, yearly once would be enough. So coming to the non-hormonal treatments. These are the non-hormonal agents which are used for hot flashes. So generally, these are the things which can also help only for hot flashes, vaginal dryness, and all these could help. So the prescription drugs which actually can be given are SSRIs and SNRIs, and gabapentin also can be considered. And the other things which actually do make a little bit of benefit are the evening primrose oil, melatonin, isoflavones are very important. The soy isoflavones are very important, and the phytoestrogens, vitamin E and yam, these contain the phytoestrogens, which are the plant sources of estrogen. So this can also help in the woman to deal with her symptoms. So SSRIs and SNRIs, they are mostly used in vasomotor symptoms. So we have to select the patient. Why, instead of giving estrogen, why we are giving these things. So in women who are, in which estrogen is contraindicated, not well tolerated, or the women who have stopped estrogen or experience recurrent symptoms but wish to avoid or cannot resume estrogen, these are the women which we can also consider women who have only vasomotor symptoms, and along with that, if she's having depression, SSRI or SNRI would be a better choice for her. And it would also be good to always include a multidisciplinary approach in these kind of women, to always involve a psychiatrist also, so that she would get a better choice, better treatment modality. So in SSRIs, paroxetine, low-dose paroxetine is the first choice, because that is the only drug which is FDA approved for the treatment of hot flashes. For women with predominantly only night symptoms, gabapentin can be considered. Only a single dose nighttime gabapentin is better. Or for women who have already been on tamoxifen, then paroxetine should not be given, and we can go to citalopram or escitalopram, because they treat hot flashes and they have minimal side effects on the breast also.